Hi, I'm Ana Brito Seixas. I'm sixth-year resident, neurosurgery resident in Lisbon, and I'm talking about UBE in spine tumors. UBE is gaining strength in all pathologies, as we have seen, as a novel minimal invasive surgery because it has a wide scope, freehand manipulation of instruments, and we can use standard instruments. I put the question of UBE in spine oncology. I search in PubMed, Medline, Science Direct with these words, and I found 9 articles that talk about separation surgery, partial corpectomy, decompression, stabilization, and total removal or biopsy. And there were 43 patients, 37 extradural lesions and 6 intradural extramedullary in all regions of spine. 11 patients underwent screw fixation and 1 partial corpectomy. So we have many lesions here in all spine segments. I want to highlight these tophaceous lesions and pseudogout that accounts for 20 lesions. That is almost half of the patients, and is not usually seen in Europe, but is frequent in Asia. So I took some pictures from the articles. This is from Hung, an osteochondroma, cervical spine, and they did an unblock resection with a very good decompression after surgery. Meningioma cervical spine with a total remotion and a good decompression 18 months after surgery. And aneurysmal bone cyst, this was a separation surgery with also a good decompression, and they did screw fixation too. So all went to general anesthesia, prone position, fluoroscopy was used in all. Some used 0 degrees, some 30. Everyone used 2 portals except Jung, that did third portal, that is mediocaudally and distal to the working portal, and he used that, saying that to complete view of the cervical remotion of a meningioma. Some used pump irrigation, some gravity, not all were described what they used or pressures. And when durotomy was done, it was 2 to 5 centimeters, and everyone used the suture except one that used the clip. So this is an image from Huzu, and these upper images are from a Prolen suture, and bottom are a Prolen with a dural patch. And here an asto clip with the CT showing the full closure of dura. So all purposes were achieved. Postoperative pain and strength improved, and early and late recovered was seen in all, and they described that. But there was some heterogeneity in reporting some outcomes, especially in mean hospital stay, ambulation. Not all described time, and there was a big variability in the studies. And post-op scores were only in a few, and not all of them were comparing the pre-op and the post-op. Some complications described were dural tear in 3 cases and spinal hypertension syndrome. This patient was re-intubated 5 minutes after extubation, but it had a good recovery, and after 6 hours they extubate and everything went normally. And orthostatic headache and convulsion in 1 case each. I think this is important to talk about because it is a unique complication of endoscopy, but I won't tell much more about because the last presentation was much better than this, and we all talked about it. So UBE is important because in spine tumor, because we can see that we can do good surgeries with minimal tissue damage, with high definition image, minimal skin incisions, and we can use normal standard instruments that we are used to. And all talked about good outcomes in the post-operative pain, hospital stays, expedite patient, but since as I said before, there was big heterogeneity, and I think that is important for us in the future to think about making some comparative pre-op and post-op outcomes. It's better for us to understand what is being done and to make some comparative analysis of outcome. UBE is an important surgery in this field, as we can see here, and it can be used in palliative or the definitive resection with few complications. And I want to thank all the people that wrote these articles and all you here that are letting us know, learn from you.
Thank you, Dr. Anne. Does anybody has a question?
Do you have any information on the time that the surgeries lasted? Like
some had, others don't, so I didn't talk about it. But the ones who told about is about 50, 60 minutes. It's impressive.
50, 60 minutes. What kind of surgery?
I can't remember.
Docking.
But
Corpectomy, probably.
but most of them didn't talk about it, so I didn't put.
I have a question to the master, because I would like to try to remove a tumor, intradural tumor with UBE, but I'm afraid to create a breach and to make surgery without repair the breach. Do you have experience of triportal with the irrigation from the monoportal? Is it okay to? Can you make surgery with the fluid? The flow is not in the second port, but in the monoportal. And other question with biportal: did you try to put another port with a drain or with a needle to have the outflow to be sure you have the outflow to not improve the pressure?
Mathieu. I did, yes, in 3 portal, but without measurement of the pressure and without a full tube for the outflow. But if you have in mind that you keep always a good outflow, it's not a big matter. And then you have the neuromonitoring that can, I don't know what is the link in between the intracranial pressure and the neuromonitoring at the moment, but if you have a good outflow, it's not a big deal, actually.
Of course, but sometimes you can lose it. And with triportal, if water go from the monoport, it's okay. You can have a field visualization and you can work without problem.
Yes, but it was an arthroscope, so it was
kind
of
yeah, but the flow is like this, you know, and not with the second port.
No, it doesn't change. The third one doesn't interfere a lot because it's a small one, just to pass the forceps to keep the dura and the tumor. And so actually it works like a usual UBE. I mean, I don't have the big experience on it, but it's like a usual UBE with a third port that doesn't interfere.
Okay, thanks.
Don't be afraid by the irrigation with the monoportal endoscope because I use it for biportal and I had no problem with the...
You have a permanent outflow from the endoscope.
There is a nipple pressure. It go out with the monoportal endoscope, so
that's my
problem.
question. Thanks.
No.
Merci. We are a little bit late. Thank you.